Hi, hello. My name is Javier Escanet, and I have the pleasure of being today at TCT 2022 with two colleagues, Nieves Gonzalo and Angela McInerney. We are a team from Hospital Clínica San Carlos, and very happy to discuss with you our history first with IVL, intravascular lithotripsy, and also some new data that has emerged from original research from our institution. So welcome Nieves and welcome Angela.
Thank you,
Javier. Nieves, it's been now nearly 4 years since it's actually more than 4 years since we started with the IVL program at our institution. And I think it's very good to look back in this journey and to think what IVL has brought to the way that we manage patients with calcific stenosis.
Yeah, so I actually remember very well the first case with IVL one afternoon. And we were all surprised actually when we started using it about how easy to use was it and how effective. So it really very quickly got one of our main tools for calcium treatment. So and after these 5 years, I think it's really integrated in our practice. So I think it's a tool that from the beginning we liked because it was easy to use. It was easy also to teach to other members of the team, and it's now really integrated in the workflow in the lab for everybody in the team, including some of our fellows that are now moved somewhere else, like Angela.
So Angela, it's true. I mean, you belong to the IVL generation of
Yes.
interventional cardiologists. Angela was a fellow with us in Hospital Clínico San Carlos in Madrid, but now she is a consultant cardiologist at the University Hospital in Galway, Ireland. So tell us, as a young interventional cardiologist, how has been your experience in using IVL in patients with calcific stenosis?
Yeah, so thanks, Javier. So obviously I came to Clínico San Carlos to do my fellowship, and my experience in Ireland was that we were not using IVL yet. And when I arrived in Clínico, the IVL program was already very established, even though it had only been initiated maybe a number of months prior to that. But I think with the results that you had seen with it, that it was so easy to use and really gave quite good results in terms of its ability to modify calcium. It got very quickly incorporated into daily practice, and it has been my experience throughout my fellowship and now as a consultant to rely on IVL for calcium modification in appropriate lesions, and I'm very comfortable with its use. As you say, I have grown up with it now, and it's very much part of my calcium modification algorithm for various calcium types.
Fantastic. Well, I mean, over the last 5 years, obviously, evidence has accumulated on the safety and the efficacy of IVL. I think I'm thinking, of course, in the DISRUPT-CAT studies that have been obtaining this information. But on top of that, there's been original research, that the one that was initiated at our hospital, and that you both have been heavily involved in it and designed the study, looking to specific features of what it is the practice of IVL. And one of them is the effect of IVL on stenosis that have either a concentric or eccentric calcium distribution in the vessel. So would you let us know about the results that you've been presenting in this edition of TCT 22 in this field?
Yeah, absolutely. So thank you, Javier. So yeah, as you said, there is accumulating evidence regarding the utility of IVL, but we very much wanted in Clínico, and both yourself and Nieves were PIs on this study, to evaluate IVL in a real-world scenario. It was an investigator-initiated study looking at the effects of IVL in various calcium morphologies. So what we have done and what we're going to present later in TCT is a multi-centre investigator-initiated study across 14 very large tertiary referral centres in Spain and Italy, looking at the effects of IVL in all calcium morphologies. So these are patients who come to the cath lab who do certainly have coronary calcium, but it's not necessarily concentric calcification or very severe calcium, and we very much encouraged people to include patients with all types of calcium morphology so that we could see the effect on both eccentric, concentric and nodular calcium subtypes of IVL. And of course, in order to do this, we pre-specified that patients should have an OCT assessment before IVL, immediately following IVL and following stenting as well. And then we analysed all of that data centrally in our core lab in Clínico San Carlos, both the angiographic data and the OCT data. And really we wanted to see what were the effects of calcium in different the effects of IVL, in different calcium morphologies in a real-world population, and whether or not there was any differences in terms of stent expansion regarding the different calcium morphologies.
So that's very interesting, because Nieves, I remember that at the very beginning we were thinking that IVL perhaps will be effective only in those situations where you have a concentric calcific distribution. So that was in a way what triggered this research, is that correct?
Yeah, exactly. So from the very beginning it was clear that it was a very effective tool in concentric calcification, and in the amount of fractures you can see in this kind of plaques, it was clear that the effect here was very relevant. But there were some doubts about whether it would work when you had eccentric calcification or when you have calcified nodules. From our experience, we thought it was effective in the sense that usually we got good stent expansion, but we wanted to investigate this in depth. And that's why we decided to design this study with this prospective registry with OCT at these 3 stages of the procedure to understand how the morphology of calcium could impact the effect of IVL.
So, Angela, would you like to share with us and with the colleagues the findings of the study, or perhaps some pictures?
Yeah, sure. So I guess we already had some information from the pooled analysis of disrupt CAD studies regarding the effect of IVL in different calcium morphologies, but really we wanted to look at a sort of a non pre-specified population, and I suppose these images that you can see here are quite similar to what we're used to seeing concentric calcium with large fractures and then good stent expansion, but really we wanted to know what was happening in the eccentric calcification, and particularly these calcified nodules, which we know can be quite difficult to treat. And in fact, we were really encouraged by our results, because very similar to the pooled analysis of the CAD studies, we found that actually minimum stent expansion and mean stent expansion in nodular calcium versus other morphological subtypes of calcium was actually similar and not statistically significantly different. So you can get very good stent expansion in these eccentric nodular lesions, very similar to what we have seen in more concentric calcification. With those typical fractures that we see in the concentric calcification, we can get the same result in terms of stent expansion in nodular calcification after use of IVL.
Very good. So from a scientific standpoint, replication of results, of course, is something that is very important in moving forward. And knowing that this happens in a real-life population, of course, is something that reassures us that IVL is both effective in concentric and eccentric calcific distribution. Nieves, any thoughts on this particular topic and the findings?
I think it's reassuring, as you mentioned. It confirms what was our feeling by our clinical practice, that it could work also in this type of lesions. It's true that the effect that you see, for example, in OCT is quite different, and maybe Angela can comment on how the images you see in OCT after the use of IVL are a bit different when you use it in concentric, which is very clear, the fractures, and when you use it in nodular, that usually you would see more like disruptions at the shoulders, and Angela can maybe comment a little bit on detail on that. But I think, as you mentioned, the data is reassuring and confirming that in a non-selected population, the therapy is effective both in calcified nodules and concentric calcification. Angela, would you like to comment on what do you see on OCT, or how is the effect in different types of calcium?
Yeah, for sure. The intracoronary imaging findings are different between more concentric calcification versus more eccentric or nodular calcification. You do see in those concentric plaques the very typical deep fracturing with very wide fracturing that we've been used to seeing in all of the publications that we are familiar with. Nodular calcium tends to have a different appearance post-IVL treatment on OCT. You can see some disruption at the surface of the nodule, but what you most frequently see is a disruption at the shoulder of the nodule where it connects with the remainder of the vessel. However, it does seem to be sufficient in order to allow good stent expansion. And as I said, we didn't see any difference in minimum stent expansion in the nodular versus the concentric lesions. So while you don't see the typical fractures that we're used to in concentric calcified plaques, with the nodular morphological subtypes, we are seeing the same percentage stent expansion at the end of the procedure as we see in the more concentric lesions.
And of course, I guess that there is room for research in the future in terms of, now that we know that the plasticity of eccentric stenosis is also modified by IVL, there is room in the future to understand if further deliveries of energy in these particular lesions softens the eccentric calcium and it becomes even more plastic or whatever. But I think these are very encouraging results. So now we could move then to another piece of research, another study that was again initiated at Hospital Clínico San Carlos, independent research. Do you want to elaborate on that, Nieves?
So I think from the very beginning we thought that this was a new therapy and some angiographic follow-up was needed to understand the durability of what we were doing and also to understand how the vessel could heal after all these fractures that you could see in the calcium. So that's why we decided to go for a study with an angiographic follow-up. So our idea was trying to do angiographic follow-up in all the patients that were treated with IVL in our center and another center in Spain, so it's a multi-center registry. We did the angiographic control after IVL. All the patients were treated more than 1 year before the angiogram was performed. In all the patients where it was possible, we also did OCT. Of course, there were some patients where this was not possible due to renal disease or other aspects such as vessel tortuosity, etc. And we analyzed all this data, both the QCA and OCT, at Clínico San Carlos. And as I mentioned, really the objective of this study was to evaluate the long-term angiographic results to start with, following treatment with IVL, also to assess if the result was durable, so the MSA was maintained at follow-up or not, and also to understand again, as I mentioned, the pattern of vessel healing after these fractures that we saw recreate with IVL.
So this is an important research, of course, more challenging because it implies performing longitudinal in vivo observations. And it was great that this study was approved and that we were supported by the patients who allowed to have angiographic follow-up and also intracoronary imaging in some cases. And obviously, it also highlights the point that we know that calcific stenosis healing is much more difficult in this situation. But first, because re-endothelialization is more complex, but also because we have learned from intracoronary imaging that you have all these cracks and you have all these uneven surface that has to be re-endothelialized, etc. So what were the findings, Nieves?
Yeah, so it was challenging actually because this was done during the COVID pandemic. So I think this was one of the challenges we had for the study, and it was actually a limitation for some patients that were really not happy to come to the hospital to get the angiogram. They would have liked to, but they were really scared of COVID at the time. So it was a hard moment for many patients, but still in the end we got 20 patients to come for angiographic follow-up, and I think we got nice data, and as you can see here in this slide, a summary of it, indicating that the results were maintained at follow-up. So this is a slide showing the minimum lumen diameter at the different time points of the study. So you can see at baseline, you can see the increase, very significant increase in the minimum luminal diameter after treatment with IVL. After stenting, of course, this increases even more. And what is very interesting and specific to this study, you can see that this result is maintained at follow-up. So there is no significant recoil, there is no significant amount of restenosis. There were 2 restenoses in the 20s, so 10% rate of restenosis in this study that goes very well in the line of percentage of restenosis in patients with complex lesions as the ones that were included in this study. So really the angiographic analysis was reassuring, showing persistent lumen dimensions maintained at follow-up.
And I think that this is important because one of the concerns that perhaps some colleagues had about IVL is that obviously if you are delivering energy to the vessel wall, you might perhaps have a response to injury that will propitiate the development of neointimal hyperplasia. But from what we can see in the data here, the median loss in luminal diameter is 0.07 millimeters, which is extremely low.
Extremely low.
So it is quite reassuring in terms of saying that with contemporary drug-eluting stents, you can really have a very good, a persistent good result in the long term.
Yeah, so if to go a little bit more in detail on that, we have a look at the OCT data that we have available for a percentage of the patients. You can see that this is again reinforced by the OCT data. You can see that really there were no significant changes in the minimum lumen area, so really not significant neointimal growth, and no changes in the stent area, in the minimal stent area. So really there was no recoil of the stents at follow-up. You can see the stent expansion was really maintained, and also the symmetry of the stent was maintained. So again, no signs of recoil and no signs of proliferative response to this treatment with IVL. So I think this is really the novel part of this study, that we have shown that there is not significant proliferation after creating all these fractures in the plaque. And actually these are some OCT images showing again the results. You can see at baseline a very calcified plaque, the cracks after IVL. Post-stenting, you can see an increase in the area. And what is interesting is the last image on the right, which is OCT at follow-up. You can see that there has been a healing. And what is new also from this study is that you can see the tissue that is covering the stent is a bright, homogeneous neointima. It's not a significant proliferation. There's not a heterogeneous tissue at this level, so it looks like a quite normal vessel healing for a lesion that you can see how disrupted was with the treatment. And even more interesting, there were some cases where actually there were some fractures generated out of the region that was finally stented. Like in this example, you can see there is a fracture there on the left at 6. This area was not covered by the stent, and after the follow-up, you can see the image on the right. This fracture has healed. So even without the stenting in an area with a lot of calcium, this was healed at follow-up. So also I think interesting and quite reassuring, healing was normal in these vessels after all this disruption generated by IVL. Still, the vessel was able to generate this thin layer of neointima, and the fracture you can see is healed at follow-up.
So I recognize actually this patient. I remember that this was one of the patients performed in a live case transmission to PCR. I think it was PCR to 2018. Mm-hmm. I remember that it was the last remaining vessel of this patient. So certainly very important for the patient to have durable results. Yes. And I think that to summarize the contribution of these 2 studies that Angela and Nieves have shared with us, the contribution probably to the knowledge that we had about IVL is that first, it replicates the results of the sub-analysis of OCT in these RAPCAT studies, in the terms of saying that IVL is equally efficient in eccentric and concentric calcific plaques, but also adds, in a way, dissipates the concern that the type of treatment that you are delivering to the artery, delivering energy to it, etc., will in return have more aggressive proliferative response or whatever. So the partnership of drug-eluting stents with IVL appears to be very safe in delivering a very good result in the long term. Angela, there were 10% restenosis rate, that is
Yes.
very few. I guess that, can you comment on what means 10% restenosis rate in this
Yeah, so
population?
as Neve said, we included 20 patients agreed to come back for angiographic follow-up, and we did find restenosis in 2 of those patients. One of those patients had actually a stent in a small artery, had restenosis in that artery previously that had been treated, and in fact was being treated with IVL for a second restenosis in that small artery. We did a physiological assessment. That patient was considered to have restenose based on the QCA results. However, the patient was actually asymptomatic, and in fact, a pressure wire assessment of that vessel was negative, and we didn't treat that patient. But we did report it as an in-stent as a restenosis event because angiographically the patient had restenosed. The second patient was a right coronary artery. The patient was asymptomatic, or at least reported being asymptomatic, but actually on further questioning probably was having some symptoms at home. We found really that the restenotic tissue was neointimal hyperplasia. There was no neoatherosclerosis in that vessel. We obviously had OCT assessment of that vessel on repeat angiography. And we treated that vessel was actually physiologically significant as well when we tested that, and we treated that vessel. So 2 restenosis events, 10% restenosis rate. However, one of them was in a patient who had already presented with restenosis, which we know those patients are very difficult to treat. And the second was restenosis in a patient who had originally a de novo lesion.
And we have to highlight that this is restenosis diagnosed in the context of prospective angiographic follow-up, which
Yes.
is entirely different than ischemia-driven
Yes.
restenosis or ischemia-driven revascularization. And also the fact that we are talking of very high-risk patients. Many of these patients having chronic kidney disease, certainly extensive calcification by definition. So I think it's quite acceptable. Very good. So, Nieves, what's next? I mean, we have covered now some areas of research, but what's coming next in terms of research in the area of IVL?
So I think there are still many things that we need to look at. Yeah. I think one of the interesting things from the analysis of these RAP studies was the gender analysis, and seeing how this technique was very effective in women, and there were no differences between male and female in how effective the treatment could be applied. And this is a bit different if we look at other treatments for calcium modification. So really is something that we need to look more in the future. And actually there is a new study that is being designed at the moment to specifically focus on female patients. We know this is a population that in many occasions is undertreated. When they are treated, sometimes they have more complications, and it looks like there is a signal that IVL can be a very effective and safe treatment in this group of patients, so we want to focus on this. So there is a study that is called Empower CAT that is going to be announced very, very soon. It's in the design process at the moment. The PIs are Dr. Lansky and Dr. McEntergaard. And the design of the study is basically an all-comers population, 400 patients treated, all female, treated with IVL and clinical follow-up until 3 years. So I think it's going to be a very relevant study. I think this idea of increasing the number of females included in clinical studies and understanding well the effect of the technologies in females is very relevant, and I think it's really a good initiative that the team is going in this direction.
I think that this is very important because typically in studies, for example, and we saw that in the Disrupt CAT trials, there is always a predominance of male patients in these studies, and therefore the statistical power we have for women is smaller. So it's very important to really move into these topics of gender. So I think that with this probably have covered a bit the the research that has been presented at TCT 2022, but also at EuroPCR 2022, the analysis of longitudinal follow-up that was presented by Nieves. Again, we believe that we are going through very interesting times. The possibility of having IVL is not only having the possibility of performing effective treatment of patients with calcific stenosis, but also from what it seems durable results in the long term. I think that's a technique that facilitates adoption of plaque preparation techniques. It's very intuitive, and obviously that accounts for the interest that the physicians all around the world have shown in the technique. And we really look forward to see more evidence coming, and of course more evidence, more adoption of the technique and comments from the colleagues that are using IVL worldwide. So with this, I would like to thank Angela and Nieves for being here. Also to Shockwave Medical, the possibility of sharing with you this research initiated at Hospital Clínico San Carlos. And with this, we wish you a very good TCT 2022, and we look forward to seeing you soon. Bye.